we know how the routine dual chamber pacemaker is going to look like. So this RV apical pacing, sometimes even RV septal pacing is going to produce bizarre QRS, which is going to produce the so-called pacing-induced cardiomyopathy, at least in 5 to 10% of the patient. So to overcome the limitations of RV pacing, people have described conduction system pacing as an alternative, where we can deploy the lead in the distal his bundle or in the proximal left bundle to activate the normal physiological mechanism of conduction system to have a synchronized activation of the ventricle and to avoid the pacing-induced complication. But for doing the procedure, at least for his bundle, we need to know we need to understand the intracardiac electrograms a little bit before proceeding to the procedure per se. So this is how the heart will look in RAO view. This is the EP anatomy of heart in RAO and LAO view. So what you have to understand is what is basal and what is apical in RAO view, and what is septal and what is lateral in LAO view. This is very important while you are performing his bundle, and it is even more important when you are doing left bundle branch pacing. So let us take a cartoon showing the intracardiac electrograms. When you place a catheter in the atrium, it's going to generate an atrial electrogram. When you place it across the his, since the catheter is right across the tricuspid leaflet, you'll be able to get three potentials. First one is the atrial potential, second one is the sharp his potential, by which you can identify the his bundle, and the third one will be the large ventricular electrograms. When you place it in the coronary sinus, of course, we know that it is in the AV groove, so it's going to generate both atrial and ventricular electrograms. And of course, the RV apical catheter will generate the RV electrogram. So knowing the his electrogram is very important because that is going to localize the his bundle, and from where you can start performing either his bundle or left bundle branch pacing. Remember, when you want to do the procedure with perfections, you need to have an EP system. This is how our EP lab setup will be looking like. So we'll be connecting the lead in a unipolar configuration, be it a his bundle pacing or left bundle pacing. So the negative electrode, being a Senjute system, will connect the negative terminal to the amplifier, and the positive terminal will be connected to either neutral electrode or Wilson center terminal. We have certain filter settings which will be a little complex to discuss here. But for those who want to do the procedure in a non-EP setup, we have the alternative. We can use either a simple 12 lead ECG where you have to keep on taking ECG, or even you can use the PSA per se, which is going to give you the limb lead ECG configuration, but you will not get the chest lead ECG configuration. Of course, in a couple of centers, I performed the procedure with a TMT monitor where you'll be seeing the ECGs running in front of your eyes. That often helps if you don't have an EP system. Of course, you have to get the intracardiac electrograms from the PSA to find out what is exactly happening at the lead tip. So this is very important. Whether you are doing a his bundle pacing or left bundle pacing, you need to know what is the electrophysiological anatomy of conduction system in RAO view. So our practice is to place two catheters from the groin. It's till date we are performing the procedure with the groin, help of the groin catheters. So one will be placed in the his bundle region, another one in the RV apex. So from the his bundle region, we'll come to know where exactly the distal extent of the his bundle is. If you don't have the luxury of placing EP catheters, take a TPA catheter, place it right at the RV apex, make it as a parabola. Usually the peak of the parabola will correspond to the superior aspect of the tricuspid annulus or the his bundle. So it's a rough anatomy of finding out the his bundle if you don't have an EP catheter. If you have the EP catheter, place it right across the his bundle. You need to get a very small A. So that will tell you which is the distal extent of the his bundle. Of course, we know that it cannot be performed easily with the conventional styler-driven leads. You need to have a catheters. Now we have flurry of catheters available. Can be either a deflectable one or a fixed curvature. The leads also, it can be either a lumenless lead, which is the most commonly used 3830 select secure lead, or a styler-driven leads. But among these, the most common thing which being used are this fixed curve C315 his sheath and the 3830 select secure lead. Procedure per se, we have to define left bundle pacing. So left bundle pacing is capture of the left bundle, either the main trunk or one of its vesicle, along with the septal myocardium at a preferably low output. So not all QR in lead V1 are a left bundle branch capture. You have to be very careful. You just have to confirm the left bundle capture before coming out of the procedure, because that implies a lot for the patient. So you need to satisfy few criteria. It's a vast criteria. We have at least 14 criteria available as of now. I'll try to make it simplify how to use it on a day-to-day practice. So this is how the procedure will be done. Remember, the left bundle fibers are on the LV subendocardium. you're starting from the right ventricular aspect. When I first hear about this left bundle pacing, I was quite confused how these people are pacing the lead on the left side comfortably. Then I got to know in 2019, like you have to drill the lead from the right side of the septum. So how to identify the target site? Identify the distal His bundle, identify the RV apex, draw an imaginary line, target the initial 1.5 centimeter. So in the initial 1.5 centimeter, you take the sheath along with the lead. Remember, it is an open helix lead. It's a fixed hub open helix lead. You cannot just simply take it because the helix are already exposed. You have to take along with the sheath. Just expose the lead tip. So only the cathode is out, the anode is still within the sheath. So you have to map in unipolar configuration. Pace it from the RV side of the septum. See whether you have W pattern in lead V1 and discordant QRS complexes in AVR and AVL. So these are very important things. A W pattern in lead V1, which is seen in almost 80% of the patient, a discordant QRS complexes in AVR and AVL. Apart from that, another important lead which you have to look for is a lead 2, which usually has to be positive. So once you identify the target site, give turn by turn. You can see the notches. Moving. Go back. So you can see the notches gradually ascending up in lead V1 to form an R wave. So once you reach the target zone, you will be able to see the left bundle potentials per se. So I'll show the fluoroscopic view. So this is how we usually start the procedure. An RV catheter at an RV apex and a His bundle catheter. I've taken the sheath along with the lead. I just placed it in the target zone. This is little high, so it's in the initial 1.5 centimeter. Once I identified that area, then I have to give rotations. So there are two ways of performing the procedure. One is the Wong's technique, where you are giving turn by turn, monitor the unipolar impedance, don't allow it to drop beyond 500 ohms. It starts from 400, gradually rises before a fall of 100 to 200 ohms when it reaches the LV subendocardium, but don't make it to fall by more than 200 ohms or an absolute value of less than 500 ohms. And give turns, and when you are giving turns, always do it in a LAO view so that you know how the lead traverses across the septum. For that, we need to know the septal thickness, we need to know the anatomy of the lead. So the lead helix, or otherwise cathode, is 1.8 millimeter and the inter-electrode distance is 9 millimeter. So altogether it will be 10.8 millimeters from the anode, distal end of the anode, to the lead tip. So you go to LAO, measure the septal thickness. For example, if the septal thickness is 11 millimeter, you have to drive 10.5 millimeter of lead inside the septum, because you know that left bundle fibers are LV subendocardium. So drive it so that the anode reaches the septum. So usually that's how the procedure we'll do, but I, a lazy person, I always look for some alternative way to try to cut short the procedure. So we came out with an entirely different way of performing what is called as a cut short procedure, shortcut procedure for performing left bundle branch pacing. So you can see in that, you could have seen in that video, the lead was rapidly traversing across the septum. So if the lead rapidly traverses across the septum, tries to generate VPCs. So we tried following that PVCs. You can see the monitor here. So the PVC starts from QS morphology to QR morphology. Once the PVC of QR morphology is reached, we'll stop giving rotation. That QR morphology beats are known as a template beat. So once the template beat is formed, we'll not give further rotation. We'll confirm the left bundle capture. So this confers lesser fluoroscopic time, lesser myocardial injury. We have, of course, documented with the troponin release, and in fact, it generated a better LVAT and better QRS duration. So once you deploy the lead, you have to confirm it. So it's a very simplified way of confirming it. So presence of QR can be taken as a major criteria. So because we are pre-exciting the left bundle, we are pre-exciting the left ventricle, you need to have an incomplete RBV delay pattern. So along with that, any one of the other criteria, if it is satisfied, then confirms that you have captured the left bundle. So one is demonstration of the potentials. You need either the EP system or the program system analyzer. Peak LVAT or RV peak time should be short and constant. You have to measure in lead V5 and V6. So this is how we measure. Take the interval from the pacing artifact to the peak of R wave in lead V5. Measure at 8 volt and 2 volt. So it should be constant. It should be short enough to confirm that you have reached the left bundle zone. Another one is QRS transition. Suppose you have two substrates to capture. When you reduce the output, you'll be able to see a QRS transition, because at different outputs, different substrates will capture. This is the mechanism. At a high output, you will have capture of both left bundle as well as the septum. At low output, you will have capture of either the septum alone or left bundle alone. So you will have a change in QRS morphology, you have a change in local electrograms. So if you show this QRS transition at high and low output, you can confirm that you have captured the left bundle. clinical implications, of course, Brady indications are there, but more than that, this is what we are looking for as an alternative for cardiac resynchronization therapy. These are a non-randomized observational multi-center study, but today we have a lot of randomized trials being recruited now. Already we have 2 randomized trials published, which is showing a promising results. But we know that nothing in medicine comes for free. We have complications. We have aborted STEMI during the procedure, which you have to stop it immediately, look for the cause, or sometimes the troponin release may be quite significant. But what we documented was we compared the troponin release in patients with SVT and ablations, undergoing ablations for SVT as well as lumbar branch pacing. What we could find out was the troponin release was less than that got released during SVT ablation. Of course, lead dislodgement is there, and we have the incidence of close to 4.6% loss of capture during follow-up. The mean follow-up duration was almost 19 months. This was among 323 patients. All these patients underwent the procedure with the 3830 leads. The need for redo procedure is 1.5%. This is probably little more than RV pacing, but it's definitely less than his bundle pacing. But the most important thing to look for is more than 6 weeks, almost 60% of the patient had loss of capture. In fact, we had one patient where the capture was lost after 2 years. We had to extract the lead and put a new lead in the left bundle lead. So you have to monitor the patient thoroughly during the follow-up, both by electrocardiographically and by doing a PSA analyzer. And for patients with an LV dysfunction, look for echocardiographic improvements as well as for the lead depth. So I will finish off with this last slide, septal perforation, which is very important to understand because, in fact, this is the most worried complications of doing left bundle branch pacing. When you are deploying the lead, there is a tendency that the lead might slip into the LV cavity, it might perforate into the septum. You can identify it on table. When you correct it on table, you don't have to worry about it because long-term follow-up of these patients who had septal perforations, they were doing really well. So our incidence is close to 14%. Before that, the reported incidence was just 2%, but in our series, it was 14% out of 219 patients. 30 patients had septal perforations. We analyzed the electrograms, we analyzed their unipolar impedance. What we found out was these were the 3 important parameters which can predict the septal perforation. And unipolar impedance of less than 450 ohms. Remember, you have to see the impedance in unipolar, not in bipolar, because the anode will actually complicate the scenario. You have to see in unipolar fashion. So if there is less than 450 ohms, you have to be very careful. If there is a sudden drop in current of injury, which is all the more important, you have to be very careful. Or if the local electrogram is of any one of these 2 patterns, type 1 and type 2, you have to be very careful. So all these 3 indicate septal perforation. Remove the lead immediately, put it at a new site. So that is very important because the lead might dislodge, will get dislodged into either LV or RV if you are just pulling it back and leaving it there. A word of caution, we know that it is a relatively new procedure. It was done first in 2017. There is no long-term data available. And this lead was not actually meant for doing a conduction system pacing. It was a site-selective pacing lead, which was done in pediatric patients, later adopted for his bundle pacing and subsequently for left bundle pacing. We don't know the long-term consequences of myocardial contraction, insulation, break, all these things. And the potential complications you have to keep in mind, least dislodgement to the LV. There was a case report. After 3 months, it got dislodged into the LV. Luckily, there was no reported cases of thromboembolic complications so far. And the lead extraction data, we don't know what is going to happen after 10 or 15 years. We have data at least 2 or 3 years. In our center, we have extracted a lead after 2 years. Vijayaraman had extracted a lead after 3 years, but we don't know the long-term data. So you have to wait carefully. The guidelines, they have clearly pointed out that we are not going to recommend it. This is 2021 European Society of Cardiology guidelines. But after that, a lot of things have changed. We have 2 randomized trials recently published and at least a dozen of trials which is undergoing, recruiting the patients for comparing them with the RV pacing versus left bundle pacing, biventricular pacing with left bundle pacing. So all these results will probably be favorable. That's what we are hoping. And the HRS and APHRS, they are going to release the guidelines in another 3 or 4 months duration, where probably a class 2 or class 2B indications will be getting for left bundle pacing. Till that, we have to be very careful in choosing the patient. We have to explain the patient about the full procedures, its consequences, and we can do better for the patient. Thank you.